I would like to thank the ISRS committee for accepting this paper as an oral presentation. These are my financial disclosures. The paper involves 24 countries around the world, and you can see those on this screen. This would not have been possible without the help of Professor Lowenstein and Shea and Batty. Again, this paper would not have been published without them. So we have the pleasure to have this paper published in PLOS ONE. It's an open access journal, so if you have any doubt or any comment, you can go online and download it for free. So let me go straight to the paper. Nowadays, we do not only treat OCTs, but also we treat patients with peripheral lesions. If we don't do anything right now, this is what happened, and the progression of traction and diabetic retinopathy. And we come here to ISRS every single year. We show beautiful videos, but no visual acuity. That is because we treat these patients very late in their conditions. And this will be even worse by 2050. The cases we are going to face will be duplicated according to this study. So the idea is to use vitrectomy and ILM peeling as a first-line option for these patients with DME. With this, we can extract the inflamed vitreous and ameliorate the oxygenation of the retina. This was published before us by Narowski and collaborators. As you can see on the video, we take first all the vitreous out, which is inflamed with a lot of cytokines, VEGF. So we clear the vitreous cavity and then we peel the ILM in order to get better oxygenation. So that was the primary outcome. And the second outcome was to investigate biomarkers and predictive factors for visual and anatomical outcomes. We are talking about visual outcomes here. Inclusion and exclusion criteria were standardized, but let me point this out. Abnormalities of the vitreoretinal interface, that is to say, epiretinal membrane and vitreomacular traction, or atrophy, of course, were excluded. Going straight to the results, we have 120 different eyes from 120 different patients. We look at different baseline characteristics, but let me point again this. These were fresh DME because they have subretinal fluid in almost 80% of the cohort, intact ISOS, almost 80% of the population of this cohort. So this is fresh DME. When we see the visual acuity, and this rock curve shows that timing, it was one of the predicted values. That is to say, it doesn't matter what we use, anti-VEGF, text implant, or vitrectomy, we have to use it early. Going straight to best corrected visual acuity, you can see on the screen that the difference was statistically significant from the beginning. The same thing happened with central macular thickness. But let's go straight to the highlight of this presentation, that is this slide. If we can check the OCT and the patient before decide what agent or surgery are going to do, timing was key. And in this case, this was statistically significant. That is to say, patients that were treated later, they fared much worse. On the other hand, or the same hand, they had fresh DME because they had subretinal fluid. And our group published in ophthalmology, subretinal fluid is a fresh biomarker and good predictive value for visual acuity. So we came out with this chart, good and bad biomarker for vitrectomy. Good biomarker is a patient that has subretinal fluid on the OCT, and bad biomarker is a patient that is a chronic, it's naive but chronic DME. But let's face safety profile. We didn't have any problem, only 17.7 increases intraocular pressure, but was very well tolerated. Of course, as every single vitrectomy, cataract progresses. In conclusion, significant functional anatomical improvement of DME after 24 months after primary vitrectomy was shown. There was no need for further treatment, that is to say laser, anti-VEGF, DEX implant, or fluoroquinolone implant. Early surgical intervention ended up in better visual acuity, and this biomarker should be considered when choosing this treatment. So we were surprised about how this worked, but the take-home message will be for every single day we postpone every single agent, in this case vitrectomy, the chances to gain 5 letters decreases 1.8 for every single day. It doesn't matter if we start with anti-VEGF, DEX implant, vitrectomy, that's what happens. But what was more astonishing for us, that in real life, visual outcomes might be comparable using anti-VEGF therapy or parasplantar vitrectomy with ILM peeling as a first-line option for this DME in naive patients. We are going to present a sub-analysis and upcoming of retina. I don't want to finish without thanking Professor Lowenstein, Dina Sroor, Javier Melamud, our co-authors, and of course our physicians, Lucas Donato, Adi Barak, Michaela Goldstein. Having said that, I would like to thank you so much for your attention.